Today's session, this is Eva Joho's talk about the topic From Collection to Cure, Managing Data That Drives Medicine. Eva is our highly valued head of the DCR division of data management. She holds a degree in applied economic analysis and is therefore an expert in data collection and analysis. Eva has been with the DCR since 2020 and brings broad experience to her role. And for this reason, I am very much looking forward to her lecture. I am sure I will learn a lot from Eva today. And with this, I would like to hand over to Eva, who will take us now on a journey through data management at the DCR. Eva.
Yes, thanks a lot, Willie, for this lovely introduction and for all the flowers already. I will try sharing my slides. Here. So also a warm welcome from my side to today's DCR lecture, which will be completely about data management. And I want to jump right into the topic. And I see, maybe you can see yourself. Now it's better, I guess. So did you know that these three really famous studies from the 80s already collected so many data points? I mean, 500,000. For me, that's really also surprising because back then they didn't have the technologies that we have now. And nowadays, international studies collect several millions of data points in the clinical field, especially if they are allowed to include big data. And for me, the question is, hey, how is it possible to manage that many data points? And how can you ensure good data quality? So that's also what I'd like to talk to you about today. Where does data management start and end? How do you get good quality data? What solutions do we offer at DCR? And how does the future of data management, in our or in my opinion, look like? So, where does data management start? In my opinion, it starts at the very beginning. So already when you start thinking about writing a study protocol, because already there you need to have an idea what variables you need to collect to answer your research questions. And afterwards, of course, you also need to have a clue about the design and how you want to implement these variables so you really get all the answers you need. Also during study conduct, data management is there helping or supporting you with change management, with user management, monitoring your data. And at the very end, and this is not even mentioned on this slide, we are also the ones that archive your data. When everything, also the analysis and the publication is done. So how do you manage to get good quality data then? Everything starts with your research question, as I just mentioned. And there you should really ask yourself, what data points do you really need to answer your research question? Not what would be nice to have, and since we are already there, we could get this and that as well. Really focus on what you really need. So your primary endpoints, maybe also your secondary endpoints. Then you should ask yourself what kind of data you need. Is it lab values, socioeconomic information? Where do you get it from? Do you need to contact an external lab? Is it from routine data in Epic? Will you need data from smartwatches? how do you get these data? Do you hire a study nurse? Will you send out survey directly to your study participants? Do you need special access to whatever system? Are there costs arising from that? And when do you get the data? So you have to already have an idea about the visit plan and the processes and workflows of your whole study. What not to do when it comes to data quality. Unfortunately, these are real life examples from studies that came to us for finding a solution and support. We had one study where the primary endpoint was missing at the very end of the study. So the whole data couldn't be analyzed as it's supposed to be analyzed. Another study, they wanted to have the information about mortality in their data set, and they found out that for having this information, they don't have the level of access, or they wouldn't be allowed to have that level of access. And this was very time consuming and cost intensive to get the information. Lots of phone calls to participants had to be done. So please keep in mind to check if you can get the information of your primary endpoint. We had the issue, or that's kind of a very common issue, that study teams think they can recruit more participants that they actually can do. And then they need other sites to join the trial. And if this is a randomized control trial, you have to take into account the number of sites when you create, or when our statisticians create the randomization lists. So that was also quite time consuming and cost intensive to resolve this issue, that a monocentric trial decided to be multicentric. And that's kind of a similar example that I mentioned with the example about the mortality. If you start your study and then you just realize that on your main site, the primary endpoint can't be collected at all, and you just realize this when you actually want to start, it's kind of too late, because everything will be postponed and again, time consuming, cost intensive. And another thing that happens quite often is that different sites, different countries have different measurement units, and this needs to be taken in account when you implement the database, or at least at the very end when you analyze the data. So now you know what not to do, and you know that you have to keep in mind what you really need regarding your research question. And now what? So the best thing to do is, of course, contact DCR DM and organize yourself a nice HRA and GCP compliant clinical data management system. To be HRA compliant, this system needs to have a personalized login. It has to be also implemented an audit trail, so everything is traceable in this database, specific rules. So meaning that a statistician shouldn't be allowed to enter data, so that you can add specific roles in this system. So for everyone that thinks, wow, why not Excel? That's why it's not HRA compliant. Also, the servers have to be in Switzerland, of course, not necessarily in Bern, but our servers are in Bern. Also, a validated system would be very good to have, also approved by the Cantonal Data Protection Office. And this is what you find at DCR Bern. Now that we talked a little bit about the system and the research question, I want to take you behind the scenes of clinical data managers' daily tasks, and start with showing you our standard process. So I've already mentioned the study protocol. When you start writing the study protocol, you could also start writing the code book. The code book is actually a description of each and every variable that you want to collect. So this means a lot of communication and back and forth for our team usually, because the study team usually is not really aware that you have to define the variable on so much details and on so many levels. I will come to that a bit later. And when you defined the code book, then you can also start implementing your database. And when you did that, then you can test it thoroughly, really. Also the randomization, in our case, will be tested. And we strongly advise you to do this too, or come to us so that we can do this for you. And if this process comes to an end, there will at some point be the magical moment of the ethics approval arriving, and then you can go live with your database and start collecting real world data or real data, which is then actually the start of your study. So then participants, patients come in and the whole process starts, and then you can see if your database really matches the reality. This is why during this study conduct, we are there also supporting you with change management. We do user management, archiving, I already mentioned. We also do data imports, and that's done by our data visualization and reporting team. So you see, we have a broad range of things we do. And just mentioning the data visualization and reporting team, they are also here to give you an overview of your data, creating dashboards. So you can monitor the data quality while the study is still ongoing and have a clue of how your data is, which site should maybe improve, how they enter data. So that's also a part of how to get good data quality data. But we also offer cloud solutions, and we are also part of teaching activities. And yeah, when you look at this whole process, there is something that all of it has in common, and this is the variable. So in the center of all these processes, there is the variable, and there are almost limitless options of how this variable can be defined. So is it categorical? Is it a date format? Does it have decimals? Is it an email address? So many questions just around the variable and how it's validated. And now maybe you ask yourself, goodness, how could I find out more about all the variables that I need? And as I mentioned before, hopefully you already thought about it during writing your study protocol. And then you can also through your code book, of course. This is by the way, very nice example of a code book we've once received. It's rather the exception, but here you can see the type of variable, the question related to it. You can see the unit, you can see the ranges if it's required, and more information. So that's quite nice to have all of it there already and thought through. Then in our systems, at the front end, it looks like more or less like this. That's a screenshot from RedCap. There you can see, okay, the variable is weight. It's measured in kilograms. There is the minimum and maximum value. You even have example how the data should be entered. And over there is a screenshot of a date field in Secotrial where you can see how the date format looks like, so that you can ensure that the person entering the data already knows how the data should look like. And the more information you provide them, the better the quality of your data will be. In the back, for us, it looks more or less like this. That's a screenshot again from RedCap. There you have the additional information about the date field, how this is validated in the background, and that it's an integer, and also you can see the ranges. So everything is there. And that's a screenshot from Secotrial, and the additional information here, which is nice to know, is that you can also add checks or logics to your variable. So when you think about one variable isolated, then I think this information is already more or less good. But of course, all variables or some of them are connected, and then you can tell the system that if a certain logic comes true, then please hide this field. Or you can add a check that, for instance, the date shouldn't be in the future, and as soon as the person enters a field or a date that is in the future, then an error message will be returned. What you can also do is adding nice calculations to the system. This is an eligibility calculation that I did once for one of my first studies, and I was so happy when it really worked in the end. So I also had to test it thoroughly, and for me that was also is the best of that's the funny part of data management, if you just try to push the system to its limits and see if it's still working, if it's still loading, is it crashing. So that's the fun part, at least for me. Now you looked at the back, or we looked at the back end of the variable. Now it's also important to have a look at the semantics and the layout of variables. So if you look at this question here, the country of birth, here it's validated as a text field, so a free text field, so people could enter whatever they want. And this will lead to lots of trouble when you try to analyze this data. And of course, now you can say, but AI could do this for me and categorize everything. But as you also know, is the fact that right now, at least for the clinical field, there is not really a AI solution that you can trust to the full limit, I guess. So for now, you still, the best solution is still to have a list of all options added in a drop down. So you really make sure how your answer should look like, so it can be analyzed in the end. Another thing is checkboxes versus yes/no questions. Here you can see checkboxes, multiple choice checkboxes about the question if you have been traveling within the last 12 months to one of the following countries. And if you ask the question like this, then you can never be really sure if the person that entered the data just missed adding or ticking the Indonesia box, but clicked on everything else. So to make sure that you don't miss any answer, then you need to add yes/no questions to each country, so that even if the person wasn't traveling to this country, then the person has to state no clearly. Other things to remember when setting up ECRF is the wording of your questions. So, for instance, did you feel sad? There is an unclear time frame. I mean, do I feel sad right now, the past 5 minutes, or the past 20 years? That's quite unclear. Then double-barreled questions. Is it now a yes to flora or fauna? It's just not clear. Then hidden assumptions is a big no-go, because you, of course, don't want to give your opinion to the participant already, so that he or she needs has the social pressure to answer in a specific way. This is also an interesting question. It's asking about a number of pills taken in the past 24 hours. So you would say to enter a number, but the unit here is milligram, so that's quite confusing. And in the end, negative questions, that's always a hard thing to think about. Is it now correct to say no, I'm not Swiss, or is it yes, I'm not Swiss? So please avoid this. Yeah. And now we discussed a lot of, we talked a lot about the variable itself, but there are several more layers. Of course, a variable can be connected to other variables, also to other forms, and then also to different visit structures. So at a certain point, your mind will just blow, because you have so many connections, and you need to think about where to adapt a logic, for instance, or a connection, if you change something. So not every system does this automatically, so you have to really know your database and realize where to adapt things. And because this is quite hard, it's very, very important to test your database thoroughly. Otherwise, it will be very complicated, and you will run into problems as soon as the database is live, because not all changes are possible as soon as your database is live. And after going live, of course, everyone that should have access should also get the access, but only the one that they need. So role specific and not more. So not that people get unblinded by accident. And in the very end, archiving according to HRA is also something to think about, because depending on the data type, you need to archive the data for, or store the data for 10 to 20 years. So it's good to have a data management system that allows that, or that you trust the people working with that system and providing you the information in the end. What is also part of good data quality is to have an overview of your collected data. And that's what the data visualization and reporting group does. Also, in the end, sharing your results with study participants, patients, and the public is something that is highly valued, I think. And of course, we know this process needs a lot of time. You now have received so many details and what to think about, and we completely understand that clinicians working in a hospital, caring for patients, maybe also supervising staff, they have absolutely no time to go in that detail when working with clinical data. And that's absolutely the reason why we data managers exist. That's our team, our lovely team, which I really like to work with a lot. We have quite diverse backgrounds. So there are psychologists working in our team, biologists, pharmacists, economists, and we even have one medical doctor. So that's really super nice to have all these perspectives coming together and supporting the medical field. What do we offer? You already have a good impression, I guess, of what we do. So now a bit about the services you can have with us. We have two clinical data management systems. One is RedCap and one is SecuTrial, and we, based on projects, we recommend one or the other. We provide a so-called full service where you actually can forget everything that I just said before because it's covered completely by us. We also offer a light service so that you can build your database yourself, and we will support you. And of course, everything is GCP and HRA compliant, and we are happy to help you with our expertise and support you with your projects. And we also have a reporting part of the team that I mentioned before. They offer automated reports, data import. So if you have data that already exists, they help you push it directly to one of our systems so that you don't have to enter it manually. Everything is also about data quality. So they provide query listings. And something that I will later talk about are the shiny dashboards. That's something that is in development. And here also a shout out to our statistics team, because some of these tasks are in collaboration with them. So kudos to them. And thanks a lot for the good collaboration. Now to finalize or to come to an end regarding this part before we start, or that I start talking about the future of data management. Why exactly should you reach out to us? I like to take this comparison. When you build a house, then you would also, in most cases, get in contact with a building contractor or an architect to help you build this house, so that everything is there and you can start living in it. It's kind of the same, I think, when thinking about databases. It's like a house for your data. And of course, we also see that there are experts that don't need that much of our support. But still, I think if you start working with clinical data, even if you have a certain experience already, it's always worth just calling us or email us to check if we can support you with a review and see if there is even something more that can be done to ensure the quality of your data. And a question that I think especially in these financially challenging times, when also SNF cuts their grants. And yeah, is the question, isn't this way too expensive? And I can tell you, we have a solution for every wallet size. And it's also important to know that at DCR, we are actually interested in the quality of your research, the quality of your data, and we will always find a solution. And our goal is that the results of your research are quickly transferred quickly transferred into real life situations to the patient, so that the patient's health increases. And so it's really like, let us help you so you can help others. Yeah, so that I think is very important to know. Yeah, and now it's the last part of my talk today is the future of data management, especially when you think about AI and that it could potentially replace our tasks. I can tell you for now, it's not possible. I checked. But of course, we are also interested in finding out how we could use AI to support or complement our work. So when creating a code book or data dictionary, or especially when testing and reviewing one of our databases, these are things that we are or we like to investigate how we could also use AI in our daily business. Another thing that we are currently looking into is the possibility that comes with epic data or real world data. So there's a work stream at DCR currently looking into this option. And one part will be that we want to push epic data directly into RedCap, but also maybe having built-in databases within Epic. It's also a topic, pragmatic trials, so that the patients don't have to come to your site and fill in data, questionnaires, whatever, so that only with having Epic data, you already have everything you want to know about your patients. And also to have alerts when potential study participants arrive at the hospital. This is, yeah, it's an ongoing discussion, but I think it's really nice. And I also think that this will be part of the future of data management. Something that we will soon, I hope, in summer go live with is our Shiny apps. So then it will be possible to provide you with interactive real-time dashboards so that you have always an overview and can monitor your data, so that the data quality is ensured, but also your budget, so that when you see, oh, quality is not as good, that you can intervene already. Then CDISC, CDASH, that's something that we are ready to offer already. This is a global standard for consistent and interoperable clinical data coding. It makes it much easier to map data across the globe and share it, because like every variable type, for instance, weight, has the same code in the background. So if someone at the other side of the world has the same coding, then it's absolutely clear, aha, it's weight and it's measured in kilograms, and that makes it much easier. And this is something that we can offer already. And what we are currently piloting is the e-consent. so that it will be possible, or is possible, that the informed consent can be captured in the ECRF. I think that this could make the daily work of researchers much easier, because they don't necessarily have to have everything in paper, but have it online, where also everything is traceable and safely stored. And then we have two other things that we are currently looking into or testing. One is RedCap MyCap. This is a feature that allows data collection via smartwatch, smartphone, tablet. So that's ideal for decentralized trials, so that in areas where not everyone has access to hospitals or GPs and health institutions, that they can also participate in trials just from home. And the RedCap mobile app is a feature of RedCap 2. It is all about data collection in areas with no stable internet connection. So there we are currently looking into the demand of this, so how many people are interested. Yeah, so you see many ideas and things we are currently looking into. And now I talked really a lot already, and maybe you ask yourself, goodness, what does she want to tell us in the end? So my take-home messages for you, for the first part of my presentation, I just want to highlight that your data and the analysis of it is only as good as your database, and the database, of course, is only as good as your study protocol. So please take your time and think thoroughly about how your data looks like and what exactly you need. The second part is about also visualizing data, so it helps you keeping track of data quality of your budget, and also makes sharing the results with your participants easier in the end, or this is a possibility at least. And please contact us at the early stage, so that we can support you early on and maybe prevent some mistakes from happening, because we are have quite an expertise in this field. So now I will close these curtains again, and are there any questions? Willy.
Great. Thank you very much, Eva, for this very nice talk. It was very interesting, and my expectations, as I'm a data junkie, are fully met. But I have a question. And the question is, these days we are talking, or we are reading a lot about fake news and false information. And all of us, and my kids, we are try hard to identify false information and to identify the trustworthy data sources. And my question now is, in the context of your data management work, I wonder if there is also a risk of false data in your data collections, and if so, how high you estimate that risk, and are there possibilities, if so, to detect incorrect or falsified data?
Yes. So, yeah, good question. And of course, yes, you can enter whatever data you want. You can fake data, but at some point it will come out. As data managers, we can't really say, oh, this is true or not. But of course, we have a really excellent monitoring team at DCR, and they do source data verification. There, they will go to the site and check if the source document, so that's a document where the data that you need for your research and enter into one of our system is collected for the very first time, and they have to prove that this is actually true. So this is how we would deal with this situation. But yes, I think just recently I saw several articles again about how researchers faked their data and somehow get it published. And yeah, I think that's a very good question. And I don't know if AI can resolve this at some point. Maybe
Or
Ben,
produce
still
data.
raising his hand, can inform us more about that part.
Yes, thank you. But I hand over to Ben.
Yes, sure.
Yes, I have a question, but maybe I can briefly come back to your discussion. I think it is very, very, very difficult to figure out fake data. What we have to do, the problem is the system, right? If the system incentivizes faking data, then the system is the problem. Obviously, very difficult to address and change, but I think that's the prime target. Try adjusting the system so that it's not necessary to fake any data. Oh, big words, but that's how it should be done, I think. I have another question regarding the future of data management, which you nicely showed this the idea of basically having real-time data feeding into data warehouses or RedCap. So, what kind of infrastructure do you think we need to actually be able to have such real-time databases? Do we need any particular infrastructure? Do you think we could run it as we are?
Sure. Do you refer to the R Shiny apps regarding real-time data and the connection to a database, or is it regarding Epic?
Epic, the second one.
There, I think to push Epic data directly into RedCap, there we are already on track. There I can tell that we have kind of a stable channel already between RedCap and Epic. So how exactly and technically it was done, I wasn't part of the project. I would need to get the information from one of our data managers. But I think there we are already quite prepared. I could imagine that it needs another server in between so that the data can be pushed to this server and then pushed to our server of RedCap. But in general, I don't think that this is an issue. But that's like, for me, the problem that we can rather solve easily. I think having an overview of all Epic data, mapping it out and realizing what it can or can not do, that's for me, the bigger question. Yeah.
But thanks, that's great to hear that you're confident about this. That's good.
Yeah. Thank
Good.
you.
Hey, I think we are 2 minutes over time. That's it. Thank you very much once again. And if you have
Thank you.
other questions, then please reach out to Eva directly.
Yes, here is my contact.
Yeah.
And so thanks everyone for joining. So it's the end of the presentation, and I wish you a lovely day. Thanks a lot.
Thank you. Bye bye.
Bye bye.